I'd like to now invite Wendy Chaboyer to the podium. So Wendy is an experienced nurse researcher and a life member of ACCCN. Her research is focused on nurses' contribution to patient safety. This work has been in relation to adverse events, clinical handover, the ICU discharge process, and more recently in areas of patient participation, pressure injury prevention, and surgical wounds. Wendy has over 240 publications and is an editor of the text Critical Care Nursing, endorsed by the ACCCN. Wendy has been inducted into the Sigma Theta Tau International Nurse Researcher Hall of Fame and is a fellow of the American Academy of Nurses and ACCCN. Thank you, Wendy.
And thanks very much to the organizing committee giving me the opportunity to speak to you today. I'd just like to first of all acknowledge my co-authors on this paper, Lachlan Thalib, our statistician, Emma Harbeck, who was our senior research assistant, Fiona Koya from QUT, Sten Blot from Belgium, another RA, Claudia, Paula Nogliera from Brazil, and Frances Lynn, a colleague of mine from Griffith. So in terms of background, we're probably all aware that pressure injuries cause pain, it decreases the quality of life for people, and it has significant financial costs for people in the community. The costs to the healthcare system are substantial. In 2014, we did a cost of illness study, our health economist led it, and we found that it cost about $1.8 billion for pressure injuries in Australia, and most of us are aware that it's part of the national standards. So we undertook a systematic review and meta-analysis of adult ICU patients, the prevalence and incidence of pressure injuries. And we looked at all stages. So we have a variety of data, but for this presentation, I'm looking at the studies that included all stages. So if some stages were excluded, this presentation doesn't include those studies. We also looked at where the most commonly occurring sites, and like most systematic reviews, we registered our systematic review. Our data sources were the typical ones you would see in most systematic reviews, and our search terms with the help of a health librarian, you can see them there: pressure ulcer, pressure injury, intensive care, et cetera, et cetera. We used English language observational studies only that recruited all patients from the intensive care because we were interested in incidence and prevalence. We looked at both cumulative incidence, or the proportion of patients who have a pressure injury, also incident rates, or that number of patients per, say, 1,000 bed days, and prevalence. Two of us independently screened, and it was adjudicated by a third person if we had problems. Studies were excluded if only one subgroup of patients, such as those who were ventilated or long-term ICU patients, or if the study only looked at one kind of pressure injury, such as device-related. Again, we had two people independently extract the data, screen the studies, extract the data, and assess the risk of bias using a tool specifically for observational studies. We did both a narrative summary and a meta-analysis using the random effects model. I'll talk about that later. And we did do some sensitivity analyses that looked at skin inspection to identify pressure injuries, so specifically looking at the skin versus charted data, those studies at low risk of bias. We had hoped to look at some subgroups and some sensitivity of other things, but things like nurse-to-patient ratio and that, there wasn't enough information in the publications for us to do other analyses that we had planned. So this is just a flow of the studies through what we've done in the systematic review. There was 22 studies that we did the qualitative synthesis of, so descriptive, and then the meta-analysis, we had 10 for incidence and 8 for prevalence, and I'll go through this in a few minutes. So just a summary of those 22 studies and the narrative synthesis. Only one study reported incident rates, and that one was 198 per 1,000 patient days. And in the discussion, I'll mention why I bring this up. Half the studies were actually of more than one hospital, which was good to see. And just over three quarters were more than one ICU. But almost 20% of studies relied on charted data about did the patient have a pressure injury? So just keep that in mind. And the risk of bias was low in about just over a third of the studies. So this, just to give you an orientation here, this is the cumulative incidence, so new pressure injuries in the ICU. What I've done here is I've just grouped them by large and small studies. So the large studies that had over 500 patients, the largest one was 4,500. the incidence was 5 to 31%. In the smaller studies, less than 500, the smallest study there was about, I think, 84. Yeah, 84, I can't quite see it there. And the range was a little bit higher, or wider, which is not surprising. So somewhere between 5 and 40% of patients in ICU get a pressure injury. This is the meta-analysis of the cumulative incidence. And I guess the important thing here is that this I-squared, this number, they say if it's either above 50 or even above 75, depending on if you're a Cochrane reviewer or not, it indicates very high heterogeneity, and some suggest you should not do meta-analysis, and others suggest reporting only the confidence intervals. And in fact, in our paper, we only report the confidence intervals. And I mentioned the one incident. So in the incidence of all studies that included all stages, the confidence intervals were from 10 to 26%. There were 10 studies. In the 4 studies that had low risk of bias, confidence intervals were 7 to 37. And the studies that used skin inspection only, the range was from 9 to 28, the confidence intervals. So keep in mind the I-squares are very high, so some people say just ignore the meta-analysis. So prevalence now, all stages, again, large studies. The largest one was over 8,000 patients, 12 to 25% range. In the smaller studies, 13 to 33%. And these studies clearly were a lot larger than the previous ones for the most part. Again, the meta-analysis shows high I-squares throughout, so we sort of tend to look at the 95% confidence intervals only, so we get these ranges of prevalence. When we looked at the pressure injury location, I haven't presented just the descriptive study by study, but same issue around I-squared. But if we just looked at descriptively, the 3 highest rated areas, I guess, were sacrum, buttocks, and heel, and that doesn't surprise it. We see a lot more interest now in mucosal and device-related, this is because this reflects the research that has been previously done. We don't see a lot of that in the systematic review. So in terms of the limitations, 23% of studies, but 18% in those meta-analysis did not use the gold standard of skin inspection, and that could really influence the results. So around 20% of studies, they relied on chart data. We did do a sensitivity analysis of those studies with the limitations around the significant heterogeneity. And as I mentioned previously, people like Cochrane suggest either report just the confidence intervals or don't report the meta-analysis at all. And we did exclude non-English papers because we didn't have the resources for 2 people to independently read all these things. We had people who did Spanish and Belgium and Chinese or Mandarin, but we didn't have a second person, so we couldn't do these other languages. But in fact, 75% of the papers of the studies were from countries that had English was not the first language. So those studies are actually being conducted in a lot of non-English speaking countries or first language. So just to wrap up a discussion, comparing to hospital data, and the hospital data is really mostly around prevalence because there's almost no hospital data on incidence. Prevalence definitely is higher than hospitalized patients. The incidence, the range is from 3 to 40. Again, the 95% confidence intervals were from 10 to 26. Prevalence was 12 to 33, and the range in the confidences was 17 to 24. So clearly, this data tells us that we do have a bit of a problem when our patients are getting pressure injuries. Now, we know that there's been a lot of work done around what is preventable and non-preventable, and clearly some of our patients are having non-preventable pressure injuries. The sacrum, buttocks, and heels are the most commonly occurring pressure injury locations. This whole heterogeneity, we wanted to do a lot of analysis of it, and some of it we could do and some of it we couldn't because of the primary papers not having the information. But clearly one of the issues is around how they measured pressure injuries. We think that there's some regional variation between sort of areas of the world. We're sort of starting to do a bit of analysis of that. Clearly there is likely to be variations in the delivery of the pressure injury prevention strategies. or in the resources. So we heard Laura speak this morning about Argentina and the resources they have to deal with compared to what we have here. So nurse-to-patient ratios, et cetera, might have influenced these. But most of this information wasn't part of the paper, so we can only kind of guesstimate about that. I just wanted to make a point that there is good reasons to choose an incidence or a prevalence, and so just be thinking about incidence is actually a better reflection on the effectiveness of your pressure injury prevention strategies. And in fact, the cumulative incidence isn't as good. So if you're doing research or quality improvement, if you can do the incidence rate where you take into consideration the length of time patients are in hospital, that would probably be more informative than just this raw, 20% of patients get it, because keep in mind, the longer the patient's in the ICU, the more likely it. And prevalence is good because it helps us understand the resource implications for what we're going to need for this condition. And my last 30 seconds or so, I'll just mention that maybe some of you guys were part of the International Point Prevalence Study that was done in May. We had for those of you who weren't part of it, there was over 11,700 patients. Clearly our work showed that we really need to have a better handle on what's happening across the world. So 11,700 patients. In Australia, we had 16 units and 285 patients contribute to this 11,000. And there will be some papers written about the Australian subgroup as well. And just to acknowledge that our paper was accepted for publication in Crit Care Medicine, where they asked us to report our confidence intervals, but not our point estimates. So if you're interested, you won't find the point estimates, you'll just find the confidence intervals. So thank you very much for your time. I'm happy to take any questions.
Thanks, Wendy. Has anyone got any questions for Wendy?
Can the studies look at any differences with regards to the incidence and how often patients are repositioned or mobilised?
So the question was around, did the studies look at some of the incidents around mobilization, I guess pressure injury prevention strategies? We were looking specifically at observational studies. So we weren't looking at studies that say, were interventionists that might have looked at does something work or doesn't work. So the studies we were reviewing didn't have that kind of information in it.
Hi, Wendy, thanks. Great presentation of what would have been a very dirty systematic review to do. People who haven't done one can't appreciate how hard they are. But you did, I think I saw that you looked from 2002 to 2016, is that correct?
Yes.
Has there been any change in prevalence or incidence over time?
Our statistician, who's a dear friend of mine, loves obviously looking at numbers, and he wants to do two things, and I haven't yet taken a deep breath to say, yes, we're going to go ahead. One of the things is around time variation. So over time, has there been changes? Some of the problems is some of the data isn't. It's the data publication, you know that. Some data, you know when the data was collected because they clearly say this data happened in this year. But other publications, you don't actually have a sense of when it was collected, or they've pooled 3 years of data, so it's very hard to think about time trends. But that's something he'd like to do. I think it's almost impossible because of the way the data is. We've been playing around a little bit with looking at GDP as a sort of a proxy measure, I guess, for sort of wealth of a country and potentially the resources. And there doesn't seem to be even a trend there. So I think part of it's around the fact that there is such heterogeneity in the studies. And so the studies are very different, the settings are very different, and I think, so, yeah. But we haven't tackled some of that yet.
Excellent. Thank you very much, Wendy.